Without further ado, I'm going to introduce Nick Decker. So Nick is the Director of Laboratory Services at Holland Hospital, a 190-bed nonprofit hospital in Holland, Michigan. He's responsible for overseeing all of the laboratory operations at the main hospital and several affiliated outpatient locations throughout the region. He got his bachelor's degree at Michigan State, and I know Dwayne's here, so Dwayne, you can fight with him about Michigan State things. Yeah, in the next 15 minutes. But I'm really excited that Nick is going to talk to us about this flexible testing idea and how he's implemented it at his hospital, and give us maybe some ideas of how we can consider implementing this type of testing and flexibility and sort of patient-centered panels in the future. So Nick, take it away.
Good evening, everybody. Good evening, everybody. Can you hear me okay? All right, excellent. Let's get started. So first, out of the gate, disclosures. The information presented is my own opinion and not that of my parent facility. Some of my consulting clients did agree to share some information, too, about their clinical review. And, of course, I received support from DSORN to be here, so thank you. So we're going to start off with some of the challenges and then, of course, the complexities that you get to deal with when you're, especially in the microbiology or virology world. And then we're going to introduce a solution, the Liaison Plex, and of course talk about the respiratory flex assay in general, and then the customizable testing solutions that we found to be most appropriate for our patient population. In general, one of the beauty points in this presentation is that you can apply this to your home facility and or to other similar sites within your systems. I've yet to find a case where it didn't help us out. So nothing new here. The challenges, they are what they are. Rising costs, reimbursement challenges, and staffing shortages. Show of hands, everybody in the audience that knows they are in a moldy X state in terms of reimbursement. Let's start with that painful point. And if you're not raising your hand, you might not know you're in one, but I encourage you to make a Google out of that and become familiar with just the variety of ways the payers want to reimburse respiratory testing. It's extremely challenging and fast-paced in terms of changes. So, of course, the staffing shortages, I have not been in a microbiology laboratory that has shrank in the last 5 years, to be quite honest. I don't know if one such lab exists. The volume of testing, the test menu, the complexity all continue to grow, but the workforce, for the most part, is aging and retiring out. And that outpaces the annual growth. So it's really challenging to keep up, and we need solutions now, not in 5 years. In terms of reimbursement, one of the things that we notice over time, as noted here in this graph, is just that reimbursement has not followed the costs, right? So costs continue to rise, and not just the cost of our analytical testing equipment or our reagents, but the cost of maintenance, the cost of labor, the overall cost of care. And the reimbursement is just not able to cover that delta that has, been growing year over year. Hospitals and health systems in general are still facing that pressure, but I think in my experience at least, and especially one of my clients in particular, they've never had to worry about reimbursement at the level they concern themselves with it today. It's always been primarily clinically driven decision making, and that's how most of us want to see it continue, correct? But one of the things that we have to do is we have to become more responsible with our resources. I obviously just listened to Dr. Chu as well, and he mentioned, being able to action off of that big spend with his technology. And I think that's key. As we start to think that way, different solutions are going to present themselves and seem like more viable fits to our laboratories, and that's key. Syndromic testing has traditionally been limited to an all-or-nothing approach. You'll hear people say, shotgun testing, we're just shooting all of our shot right out of the gate, and unfortunately, it's given us a bit of a bad rap in the laboratory world. Higher costs are showing up, and we look as though we're not necessarily qualifying our patients appropriately for that multiplex testing. You hear a lot about overutilization. Sometimes, though, equally important, we are underutilizing for fear of retribution. So if you talk to your infectious disease clinicians, especially emergency room providers, I hear that a lot. I'm always talked to about my over-testing, never my under-utilization. And so we want to be stewards, again, but we need to understand kind of what's behind that, what's driving those reimbursement strategies. So one of the first things we noticed is that the bacterial and respiratory targets that are on this panel, while they're coded a little differently, most of the payer policies focused heavily on viral targets in the count. And so it's important to remember that you have these tiers out there, regardless of which health plans you're dealing with. And these tiers typically say, I will not find outpatient testing to be medically necessary if it's greater than X number of targets right out of the gate. And so that's a pretty common thing we're seeing in the industry. But for a long time, we've been stuck with saying, well, I'll pick on another vendor here, but my BioFire panel is a certain size and I can't really do anything about that. So I can't just use a different solution. And you'll start to see other vendors picking up on this too. You're going to start to see what we'll call mini panels or small plex panels. You'll start to see that nomenclature out there, and people are saying, hey, we have the ability to light up 25 targets, but is that the right decision right here, right now for this patient? So one of the biggest challenges is that we want to take care of all of our patients using the same process, the same workflow, and if you're in a hospital laboratory like mine, 24/7 operations, right? So I do not want to have a separate workflow for my night shift staff, who are typically fewer in number and with less experience than my primetime day shift staff with my very tenured folks. And so when considering, how you multiplex and select tests in your menus and builds, it's important to remember that we do have two distinct populations in the eyes of the payers and as well as the clinicians. Outpatient and inpatient. Our outpatient testing is typically reimbursed based on coding, right? So both my test CPT code as well as a diagnosis code, a matchup on the backside there by the payers, and then reimbursement follows. There are some managed care or managed health plans that will pay based on value-based numbers around that, but keep in mind that still at the front end of that decision is usually a coding matchup. Inpatient, however, is typically covered under DRG or diagnosis-related groups. And so when you think about the changes there, our inpatients are typically at least one night in the hospital, but there can be issues where we take a patient from the emergency room, we put them in an observational type unit, they pass over that 24-hour mark or something along those lines, and they hop the fence, if you will. And when that change happens, they fall under a whole new reimbursement structure and strategy. Typically, this is also where we start to get clinician feedback that says, hey, I want higher level of coverage, syndromic testing, panels, et cetera, because this patient is a higher level acuity than somebody else that you might be instructing me to use a smaller option for. So just keep that in your mind that we're designing these panels kind of with two distinct patient groups, even though they might present with the same symptoms. So we're going to talk about a solution and one that we have deployed now since October of 2024 in my facility. We were very early adopters. We have been complaining for years about the need to have a customizable syndromic approach. And so when our friends at DiaSorin showed up and offered one, we were very quick to jump on it. Some highlights: room temperature storage is fantastic. I don't know about you, but coming out of the COVID era, every different mix needing a different environment, chewing up fridge and freezer space was always a nightmare. QC materials being different than actual test cartridges was also challenging. So we took advantage of the ample room temp storage. Obviously, it's a scalable solution. You'll see multiple bays there. They are truly random access, which is always appreciated in syndromic testing. And of course, it's got a nice touchscreen interface, and the ability to go sample to answer as a workflow keeps it very simple for adoption. Again, like I mentioned, you can deploy this in somewhere like a small community health clinic. You might have a very small regional affiliate in your system, and it's very uncommon to see something at your flagship enterprise hospital that you can also deploy across the board like that, especially giving up expertise or tenure, let's say. So let's talk a little bit about the assay itself. So we obviously have RT-PCR, and surprisingly to nobody, we know we need to have bacterial targets as well as viral targets. So just take a minute and review kind of this list with me, but one of the first things that I noticed, at least, is that we were sticking with a nasopharyngeal swab. And although the patients, and I've been a patient so I can complain, that's not the most desirable solution, obviously, for a patient in mass. I do feel like that was one of the first things in my mind, was just that I know my clinician's doing a more invasive swab. I know they've at least thought about it, and or the patient has thought about it. And so we're selectively saying, yes, this is the right patient to test. yes, we do need to go to something a little more invasive like a nasopharyngeal swab. We're detecting nucleic acid gene sequences of the following organisms, and there are some subtypes available as well. So let's talk about some of the ideal design features that you might be exploring in your laboratories. One of the things that I encourage you to do is stay very up to date on the epidemiology in your environments, especially those of you that come from larger systems that have different patient populations. You might have a system that stretches 6 states. You might be responsible for an environment that's a little more isolated or remote or rural. Obviously, there's a seasonality component to this type of testing, right? We don't see the same pathogens year-round or in the same proportions year-round. They do tend to fluctuate a little bit. Of course, we want to deploy an algorithm. We want to try to be better stewards, and we want to give the clinicians something easier to work with. The patient profile, we tried to just keep it very basic and focus on our inpatient versus outpatients. I have seen a few of my clients in particular really hone in on the pediatric population just because of the patients they serve. And again, this is a solution that I feel like will do positive things for that workflow. And then, of course, reimbursement, the ability to deploy a solution in smaller, more focused areas does leave your outpatient reimbursement available. So that can have a giant financial impact at the end of a full flu season. As I mentioned, we started testing patients roughly in November of 2024. So I did not encapsulate a full flu season with my system when we first deployed it. We projected 6 figures worth of financial improvement to the bottom line just by containing the overuse of 20+ target panels. And I'm proud to share that we not only achieved that, we yielded a 10% higher return than we even budgeted, and we did not cover a full season. So that was great news. That'll keep your CFO very happy. So thinking about kind of how do you build that first panel, right? We do not have the means to deploy a large amount of PhDs or hire epidemiologists to get that first one out of the gate. DSORN did a very good job of publishing a white paper that I felt was a strong enough tool that we did not have to sit back and gather data for 6 months before we deployed it. That was ideal for me because I mentioned I come from a community hospital. I have limited resources compared to an academic medical center in that arena. And I really wanted something that I could deploy same year, same full flu season, take advantage of all these respiratory targets using that customizable approach because we know it's been a thorn in our side year over year. So we did lean on this heavily for seasonal and demographic trends. There was a lot of information in there that we just found very useful. We met with our scientific colleagues at DSORN to make sure that we weren't over or under reading the data. And we started to think about how to build this in our LAS. So one of the things that I wanted to encourage you to think about was just knowing that we've got these 2 distinct patient populations. We don't want to introduce our clinicians to 45 miniature panels right out of the gate, right? We will overwhelm them. The phone calls will come in. Show of hands, how many people directly interact with their customer service department? Especially outreach, right? I see some hands. You know that phone call rings every time you make a change in your emergency room, inpatient or outpatient setting. Change a swab, change a color cap tube. It's all over, right? Phone's ringing, the emails are flooding, and here we go. We spent a lot of time trying to think about who are these different groups of patients and clinicians and what would they want to see. And some of these panels that we deployed with immediately, we had no intentions on building out of the gate. I want to draw your attention to the outpatient POC reflex, or what we call the POP, the post-office panel. One of the first things we encountered was a lot of the clinicians that had their own urgent care, standalone clinics, or rapid testing sites, they said, hey, we're already testing for a lot of these pathogens that you have in this panel. We don't want to duplicate efforts. We want to give a better yield. So what we did is we designed that panel in particularly and said, hey, if we needed to deploy one to one of our outpatient clinics, we want to enhance the testing and the value that they're providing to their patient, not just add another billable with a higher quality or higher level methodology for the same targets. And so that's a way that you can collaborate with your outpatient clientele and keep them happy while they go on this journey with you. Happy to say we did not lose any outpatient clientele with these changes. And considering we had to go from nasal swabs to nasopharyngeal swabs, I'm pretty impressed with that because first thought in my head is, they're not going to want to work with me anymore. They're going to turn me loose and kick me out of there. Another one that we saw right away too is that our pediatric and adults in the emergency room typically have very different workflows. And I'm sure as you go back to your facilities and discuss with your clinicians, you will see that. I did not have to drive them to a different methodology or a different type of solution, simply a different panel out of the gate to make them happy. One other challenge that we encountered, as many of you might have dealt with in your own laboratories, we had an unseasonably large amount of mycoplasma identified, and including from other facilities that would have patients with negative testing that would present to our facility with no recovery on those symptoms. Maybe they have more of an atypical pneumonia. One of the nice things was we were able to deploy that quickly and rapidly. The targets are already validated, everything is good to go, method verification is done. The need arose, we built and deployed this panel, named it responsibly to keep over and under searching under control by the clinicians, and that way they were still able to get, again, an outpatient reimbursable panel, helps me help them, and they have checked the box saying, did I check for X? Talking a little bit about the coding, one of the things that we struggle with as operations folks in the laboratory is the solution sounds great, but I need to be able to deploy it. And I'm not a PhD with a coding background, right? I do not understand that as well, or I'm not as strong there. One of the things my clients brought to my attention actually before I even thought about it when they were considering the Plex solution was, we already have most of these CPT codes built. We're just not simply bundling and deploying them the same way, or the nomenclature is a little different, but the coding is the same. There's really not 45 codes to deal with. You do have a select code for each bacterial target, which we've highlighted there and color-coded on the far right. But in general, these are categorical codes. So think about toxicology type testing, right? GO 480, 481, 482, there's a sequence based on the number of targets you are bundling. So it's actually exceptionally easy to code as long as we kept our panels very similar in terms of size, and that was one of our goals because we do have a MolDX state in play here. So that 5-cap target is very real. Another challenge too is integrating to the clinicians that they don't have to change their practice. They are going to get viruses and bacteria where we have agreed upon. They don't have to make a different, distinct selection. We had a lot of clinicians in the beginning question whether or not they would have to order something different just because, hey, your old test used to say respiratory viral pathogen profile or something along those lines, and that's not a virus I'm after. I'm actually after a bacteria. So we clarified that, and we actually deployed a similar grid when we were making building decisions, and that way they got to provide their feedback before anything was ever live, even in the test system in our EHR or LIS. So that was really helpful. They already knew what was coming. Lab memorandum or update goes out to the clinicians. They already know the answer because they were there helping build the panel. Another challenge that I wanted to encourage you to think about is everyone has a different LIS and EHR. We went through a lot of trials and tribulations deciding the best way to do this because we wanted the ability to change this panel seasonally and or in the future if trends emerged, but we did not want to go back to the drawing board, rename, re-ingrain in all of our power plans or ordering plans out of the gate. We did not want to have to go down that journey 6 months into this. We wanted adoption to be clean, simple, and straightforward to our clinicians. One of the things that we opted to do, and you don't have to do it this way, but just something to consider, is we actually built every single panel with a full batch of the targets available, and we suppressed or test not performed or hid those fields for which we were not going to answer. So we kind of built them backwards. Here's all the targets. You want these 5? I'm going to suppress the rest of those. And I know everybody's EHR and LIS combos are going to be different, but remarkably, out of all the big names that I've played with so far, this kind of a tactic does seem to hold true. The other very important part is if you do and are fortunate enough to be blessed with epidemiologists or data scientists that can help you out there, historical results searches are all intact now as well. We have one respiratory panel year over year, even though the targets may be a little bit differently. And we can go ahead and clump those together and search those parameters cleaner. We can generate more evidence-based data for changes in the future. And that'll make your clinicians very happy, and it'll also keep you feeling confident you're making the right call at the right time. So back to the considerations, right? How do you build the perfect panel? This is not easy. It took us quite a bit of time. I think now when I advise my clients, I tell them to budget for 6 to 8 weeks if they're considering a change like this. A lot of them are just like, that's crazy talk. That's way too fast. But we do give them a lot of the painful trials and tribulations that one of us went through the first time around. And that has really cleaned it up. And of course, our friends at DiaSorin watched this intently and said, this seems, to be somewhere where we can offer a little bit of guidance, right? As a vendor, let us help our partners in the laboratories do this cleaner the front end. So at our table, we had, of course, the common stakeholders that are clinicians, infectious disease docs, ICU, ED, urgent care, and most importantly, the LIS and IT teams did have a seat at that table at that time. We met with a regular cadence, and this core focus group helped guide the discussions. You want to keep that table very diverse, but you don't want to make it too large. Too many voices, and you start to lose a little bit of that speed and progress, right? Thinking about those larger academic medical systems in particular, if everybody held their own table at each individual site, we would really struggle, right? So that's something that we want to keep in mind. Of course, from build to bill, the solution is no good if it can't be built or billed appropriately in an automated fashion up front. Nobody wants to go in at the 11th hour and change a bunch of coding, change the nomenclature, republish everything to the clinicians, call up the outpatient and outreach clients, and try to shift the focus real late in the game. The mapping of panels proved to be a little challenging at first, but once we kind of looked at the suppression process and how to hide fields, it really sped right up. We actually were able to make a lot of progress quickly. When to reflex? This was one of the first questions we argued with ourselves about quite a bit, and I heard a few of my clients too bring this up. When do we want to reflex to that full panel? In a lot of workflows, that's a decision we haven't had to make, right? We've always been forced to go all the way with that panel no matter what. But when you start offering 5, 6, 7 targets out of the gate, there is a decision point where you might want to consider a reflex. For us, the answer was pretty straightforward. It was the DRG change. When I go inpatient and the emphasis is on acuity, length of stay, potential intubation, or vent activity, I'm automatically not too concerned with reimbursement on my laboratory test. I'm burning hundreds, thousands of dollars every hour maintaining that patient and trying to keep on top of the clinical outcome, right? And that's still paramount to what we're trying to do here. So as soon as we made that decision to go ahead and move inpatient or to jump to the ICU, for example, we built reflex process into those rules so the clinicians could know, hey, you got my back. We're going DRG, we're going length of stay. I have the very acute and or immunocompromised patient in front of me. This is when I need all that information. And so that's an automatic reflex that we decided to opt to at that point in time. Future-proofing the panel is something we didn't want to lose sight on. Hey, we got to roll this out quickly. I'm getting started. It's already August. I want this thing online in October. And as I mentioned, November was go time. So we really wanted to make sure that we just built ourselves a way, especially with the suppression of those boxes, to change this panel in the future, keep the nomenclature similar, keep the order set similar, and not confuse the clinicians. So again, keep in mind that this is going to be discussions on stewardship, clinical relevance, and of course, financial sustainability. So in conclusion, customizable testing supports smarter diagnostics. Smarter diagnostics make us all look better at the end of the day. The tiered and reflex panel strategies do keep your costs in check while still delivering actionable data. And you can successfully implement this. Keep in mind you want that cross-functional team. Make it easier on yourself, adopt it with a win. Thank you.